Good morning, everyone. Welcome to our webinar. Thank you for joining us. I'm joined by the wonderful team at Royal Flying Doctor Service SA and NT. And today we're talking about co-designing digital healthcare with rural and remote communities. Before we kick off, an acknowledgement of country. So Five Faces and Royal Flying Doctor Service acknowledge the traditional owners of country throughout Australia and their connections to land, sea and community. We pay our respects to elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. A little bit of housekeeping before I jump into introductions. We do have a Q&A sitting there in Zoom. So if you do have any questions as we work our way through the next 40 or 45 minutes, please pop them in the Q&A. We'll try to answer them towards the end if we get time. If we run out of time or need to seek some further advice to answer your questions, we will come back to you post the webinar. And we'll also, as we work our way through, we're going to be triggering 3 polls to ask your perspective on a few questions. They are anonymous, but would be great if you could participate. And in addition to that, we'll be sharing a recording of the webinar with yourselves and everyone who has registered today. So I'm Rachel Wolf. I'm the Chief Customer Officer here at Five Faces, and over the last 18 months to 2 years, I've had the pleasure of working with the 2 wonderful ladies that you see on your screen today, Hannah and Michelle, but I'll let them introduce themselves. So Hannah, would you like to kick us off with introductions?
Sure, thanks, Rachel. Hi, everybody. I'm Hannah Allett, and I'm the Patient Experience Partner for the Royal Flying Doctor Service across South Australia and the Northern Territory. It's a friendly, warm title for consumer engagement, really. That's my bag. Hi.
Thanks, Hannah. And Michelle.
Thanks, Rachel. So my name's Michelle Doby. I'm an ICU registered nurse by background. So I've been with RFDS now for about 6.5 years. So working currently as the Principal Advisor of Digital Health Systems and Projects. So anything that's sort of got a touch point in the digital space for clinicians, etc., I'll generally have a touch point in. So,
thank you. I'm going to stop sharing and we'll kick off with today's discussions. As I said, please put any questions as you work through in the Q&A. But for those who may not be familiar, and I have to admit, when we first started working with Royal Flying Doctors, I thought Royal Flying Doctor Service was a national organisation. I didn't realise there were these different arms and different states. But for those who are joining who aren't familiar with Royal Flying Doctors SA and NT, and the communities that you support across rural and remote South Australia, can you just give us a rundown on what you do and how you work? I might start with you, Hannah.
Yep, okay. We've got in the Royal Flying Doctor Service, as you indicated, Rachel, we have a federated organisation. So we've got our federated states and territories all have independent boards governing their services. However, we do have a federal board, and they are responsible for all the Commonwealth contracts and Commonwealth funding arrangements. There's often jokes amongst us that we're great family until it comes to Christmas and we want to carve up the dollars and we start to get a little bit possessive. So each independent state and territory is boards are responsible for their own fundraising and service delivery. We have here in South Australia and the Northern Territory unique setup where we've got that whole central corridor really of Australia. So we're providing healthcare, we like to say, between Kangaroo Island and the Tiwi Islands. I'm not sure if people are aware of where that is, but it's that big the waste of as in this space of Australia. And we have in our patch, it's nearly 2 million square kilometre service area.
Wow, huge.
It is, it's massive. And within that catchment, we've got over 40 identified Aboriginal languages. We've got a wide variety of transient workers who are either working on stations or in roadhouses or in trucking services and transport freight. Or railway lines, and we've got Aboriginal communities, and that's pretty, yeah, no, I'm tourists.
And tourists.
And tourists. Our most common aeromedical retrieval is a German man in terms of tourists. For this project, we really are focusing on the work that we do in remote South Australia. It's often called the outback, and in that catchment, we've got just under 50 locations that we are delivering primary health services to, and allied care and dental and mental healthcare, as well as the aeromedical retrieval. The screen you can see behind Michelle and myself is one of the stations, a smaller station in the Gawler Ranges of Outback SA.
So you've got diverse population, huge geography,
massive,
and you have to adapt to deliver services differently.
Absolutely. And when you think about the healthcare standards, the assumption, rightly, by the Healthcare Commission is that you've got a facility from where you're delivering your services, and that changes for us all the time. The location of where our services are delivered is always in flux.
And it's interesting, like, I'm in Brisbane, so I work on the assumption that I have a large tertiary public hospital just, a footstep away almost. And as Five Faces, we do work a lot with large public healthcare and metro areas. And then working with RFDS, you see the broad range that's required. And I might go to Michelle. Have you got some examples of how the way you deliver and need to deliver and support your communities is different to what we might expect here with, in metro and in our cities?
Yeah, so many of our communities have, high levels of chronic disease. So, Aboriginal community members have, shorter life expectancies and things like that, and higher needs. The work environment that these people work in is, challenging. So they're not at their home. They might be away mustering for, weeks at a time. So they're, living out of utes and tents and things like that. So the distance and isolation that these people face is a major barrier in accessing healthcare. A healthcare facility is not 10, 20 minutes down the road. The service delivery for us can be affected by extreme weather events. Like we've got recent, people may well see there's been significant flooding in a lot of areas. They're subjected to, extreme heat on the other end of that spectrum, other weather disruptions. So, we have to use a flexible sort of on-demand approach to, how we get to these communities and deliver healthcare. How we reach them. So, each month to month, our bush run, might look different. That we utilise, they're booked on demand to reach these, areas. So
the bush run is a different service, and I think I've said to you before, like I even talk about that at home because you don't realise that these things happen. So if you can tell us a bit about the bush run and how that works and how it's scheduled in.
Yeah, so we have 3 different bush runs as such. So we have a central, a northeast, and a west. So they sort of we fly out from our Port Augusta base and fly out sort of to different areas, so either up centrally, north or west. We have a list of regional locations or remote locations that are allocated to those 3 particular bush runs. And it's not known from, 1 month to the next where we'll be flying to. So we might fly to, a particular 5 different locations or 5 locations in the central run this month, but then it'll be a completely different 5 the next month. So basically, the flight plans are not determined until our bookings close off at 12 o'clock on a Monday. And then the flight plan's determined on the Monday afternoon, and then on the Tuesday, Wednesday, Thursday, we fly out to where the demand has dictated that we need to fly to. So, and the healthcare, as Hannah mentioned, we're not flying to, a location where we've got a bricks and mortar building. Sort of some people we're telling to meet us at the airstrip, and the clinic is conducted out the back of the plane. So, you might have a stream of, a few cars parked on the airstrip, and you person gets out and is in the plane for their session, and then, or their consultation, and then off they go, and the next person comes. So it's literally, there might be a community facility that we get picked up from an airstrip and driven to deliver, care to whoever needs it in that community, or as I said, it's out the back of a plane.
Yeah, and I guess telehealth, I think you've said in the past, is essential, but they can have connectivity issues out there as well. So it doesn't always work, and you also need that in-person touch as well. Yeah,
exactly. So this is our face-to-face, but as I said, sometimes our telehealth is literally a phone conversation, because that's all the person has got to be reached by. So we did find when we were doing our community consultation that some of the devices that people have in these communities, we've got an aging, demographic in some of these areas, and they don't have the latest phone, that's out there. So that also has to be taken into account as well.
Yeah, and then so working across the communities spread across different parts of Australia, remote. We know RFDS is a really trusted brand and service, but Hannah, particularly, in your role and for your experience, like how do you build the trust and relationship with the communities, particularly, a lot of disadvantaged and diverse communities, to shape the services?
The trust is very much a part of the good relationships that our clinical teams have with the communities. So they're going in regularly to see and care for people across the broad spectrum of primary services. But so that's wonderful and great, and we can get those kind of relationships formed in really bespoke ways. But the wonderful thing about remote and regional towns out here is how resilient, how tough, how terrifically connected everybody is, because they do rely on each other to be each other's first responders. They do rely on each other to be each other's confidants, best friends, co-workers, co-cooks. And when it comes to privacy issues, I think that's where we get into some really tricky territory. In Aboriginal communities, there can be poison relationships based on the kinship system through marriage customs. There can be one trucking town that we deliver services to has a very transient group coming through frequently, and the stories that waft around that town need to be really protected at times. And so, there are a lot. I mean, but we're,
So
it's a country practice in a really big way, Yeah.
So is that done just sort of by ad hoc communications, or do you actively run some programs to seek community advice?
So all of the stations that the Bush Run does its station hop across, and the roadhouses and townships and the communities that we do that hop across, we have on the ground, we call Champion, the
Mhm.
community champion is on the ground, and our the manager of the primary health and allied healthcare program will get in touch with the champion to say we are coming out tomorrow. We'll be coming out next week. The 16th is guaranteed. We'll be able to be on the ground for this many hours, for 4 hours, and if we don't fill the book, we'll move on to the next, Copley or the next station, where she'll then get in touch with the community champion. So you can understand that that is very, very time consuming.
Yeah.
And what the solution we came up with you guys was aiming to do was help fix that solution so that people had an ability to be in control of that themselves. Community champions can talk to Mandy, our manager, and people who can have the rights, meet their own healthcare rights to have privacy when it comes to making appointments or engaging with the doctor.
Yeah. So how did you hear that the community were looking for a digital solution to book their
Uh,
appointments?
So in a big part of how we get our funding is going out to our communities with extensive surveys every 5 years or so.
Yeah.
And in 2021, that whole remote SA outback area had a health needs analysis survey and loudly loudly said we really, really want a digital booking platform
Yeah.
for these services that would just make such a difference to us. And so we listened and
Yeah.
put it in the business plan for the next strategic, period.
Mhm. So then when it came to delivering something, um, the services that you offer to the communities that you offer to the clients or patients that you support, I might go to you, Michelle. Like we really did have to design something that was quite bespoke and specific. So how did you consult with your stakeholders internally and externally, and how did that shape the unique requirements to deliver this?
Yeah, so firstly, we started by doing some on the ground focus sessions. So Hannah and I went out to these communities. So we travelled out and made a time, with them to sit down and, listen. So we said, some of the communities had already had sort of a bit of a solution. There was a couple of communities that were newer to fall into our service area. So there was some sort of changes that they had sort of faced. So we targeted them first, I guess, in a
Mm-hmm.
way, sort of to try and see how we could meet their needs and bring back what they had lost. Bearing in mind that our service delivery was a little bit different to what they had received in the past. So we sort of had to sit there and let them well, feel free to sort of like let us have it, in a way so that we could sort of, allow them to sort of vent and really find out what their pain points, were so that we could try and address them, at the highest priority. So we really needed to understand their local needs and the challenges that they faced. We also did some surveys, out to, the bushrun locations, because obviously some of those locations are harder for us to get to specifically. Hannah has some really good relationships across and has some linkages into some of their local community, groups as well. So we utilise sort of that as some of our entry points into reaching some communication with them. We also sat down with our teams, the teams that sort of fly in. Like even though we've got quite a fractional workforce, we try to ensure that the staff going into the clinics regularly are the same, so that they can build those relationships. So we talked to our teams as well. To sort of see, well, where they saw we could, meet the needs of the communities as well. So once we'd sort of had those sessions, Hannah and I got together and we developed some user stories to present back to, relay those or describe those requirements. So And then we presented them back to our staff and also to the communities to sort of see how we could shape the design and make sure that we were giving them a good user experience in that process. So once we sort of had something a little bit tangible, we then we utilised some of our community members as our user acceptance testers. It's one thing for me to sit, in an office in front of a computer and click through a system to book appointments and tick a box to say that works. But we actually created test accounts for a team of our community members and got them to test and feedback what works, what did they like? Did they like the look of it? And things like that. So it was a real sort of elements of co-design in that whole process before we sort of actually released the final version.
And probably a unique experience for them and quite exciting to see it all the way from, an idea through to testing the product.
Yeah. And we actually probably had about 15 to 20 people that put their hands up to actually be testers. So, for us, I think that's, it's great engagement. So to want to be involved and to feedback and it's good that because then we were able to show them that once they sort of put a suggestion forward, we were able to then actually show them something tangible in the back to sort of show that we'd heard what they'd said. So
then speaking
and
I'm sorry, you go, Hannah.
Sorry, Rachel. I was just going to add to what Michelle said that when we knew that the software design was going to start, that process would be starting, and we went to the consumers to do that engagement. There was a survey that went out asking about their the communication methods that they currently use and what they prefer, and what that sifted was that there was a large cohort out there who were terrified of digital technology. There was a large cohort that was suspicious of digital technology, and they wanted a lot of reassurance that they can still use the phone and call Grace, who's the receptionist they've got the relationship with. And it's just been beautiful watching some of those resistors be early adopters, because we did go on quite the journey of engagement around user testing and over that time. It was a beautiful thing to see.
Because that was right. We had to be very conscious because of the range of demographic that we had across these communities, that we weren't coming in and saying that this now is going to be the only way that you could book appointments, because we had one of the sayings that I've got next to my desk at work is like, who are we excluding by design? So, this might be fantastic. And if you're computer literate, it's amazing. But then who are we going to exclude by bringing that in? So we had to make sure that we were very clear in our messaging to say that this is just another option for people. But Hannah is right in saying that, one of our communities that had the loudest voice in saying what they wanted and didn't want are now one of our highest utilisers, of the system. So, it's really amazing to see that.
Giving the choice and saying, you don't have to use this, actually does build the trust. So,
Correct.
So speaking of feedback, I might just launch a poll. So for those online, we've just got a couple of polls to trigger throughout. And the first question is, how involved are patients or communities in design of your digital health initiatives today? Are they deeply involved through co-design, as the RFDS team might respond, consulted occasionally, informed after decisions are made, limited or not sure? And I think we'll probably have a very large range because it is quite an investment to bring in co-design. And my advice is always, don't ask the question if you won't listen to the feedback. So, and that's the tricky part that you do come to at some points. We're gonna ask for feedback and co-design, but we need to take it on board to an appropriate level. So I'm going to end that. We can see there's a real mixture coming through of deeply involved and mostly informed. But we do have about 30% saying limited or no direct involvement. I'll share the results so that you can see them. So real spattering across those responses there, which is interesting. And probably not super surprising that we have that range. Were there
Interesting.
any requirements or feedbacks that came up, Michelle, that might surprise the audience or surprised you?
Yeah, we had to be one of the strong messages that we got through was the ability to book on behalf of. So I remember distinctly one of our community members waving her phone, at us in the session, going, "Well, I don't know how to use an app." She said, I get messages and I get um like, oh, sorry, that's distracting.
Sorry, we actually have a fire drill just playing over there.
Oh,
Yeah.
Perfect timing.
I couldn't work out whether it was here or what.
I know. I was
Yeah.
like, I don't know if you can hear it, but
Yeah.
please, I'm going to mute.
Yeah.
And
Sorry. Yeah. So we had her waving her phone at us saying that, I don't know how to use an app, but I can get a text message or I can use my phone for calls. So one of the messages that was loud and clear from her is that she'd be happy for someone to book on behalf of. And in this particular community, that is a mechanism that they had. So one community member would book appointments on behalf of some of the older community members. And we also had that messaging from parents wanting to be able to book specific appointments for children. So that obviously presents a challenge in relation to privacy. So we had to be sort of measured in the information that obviously that was required to be able to go ahead and book of, and to ensure that it was just basically a name, address, and a date of birth, which essentially these people would know about their fellow community members anyway, but then no other identifying information about the type of appointment, that was required, was being booked, was made visible to that person. And once it was booked, then any other communication went directly to the person that was booked on behalf of. So that was, a little bit of a unique challenge we sort of dealt with. So the other thing that was loud and clear from the community is they wanted two-way messaging. So the community members wanted to be able to message back to us. So how far away is the plane? Who's coming today? Were some of the questions that they were asking, so that we could respond back and confirm, which staff were coming. Because we quite often, if we're caught up at one location before we're able to, and it could be a weather, it could be just a delay in seeing patients delayed, so that we could then use that messaging to then communicate in bulk. So rather than having to message individuals, we could send a system message that would go to all people that would potentially be booked in, because we could see then from a dashboard now who we had, coming at the next stop. So that was one of the other uniquenesses, the two-way messaging functionality. With our bush runs, like generally, I think some of the larger platforms that are out there, you book to a location, you book to a clinician, and you're booking a time. With the bush runs, you're actually only booking to a location. So, I think some people might find that, a bit daunting, because you're saying that you've registered for appointment, but you don't actually get, the full confirmation of what time. So, the reliance is there then on the messaging to send that confirmation once the flight plan is determined. So that was a little bit of a uniqueness to our requirements for this build as well. So
I do apologize. I've still got the alarm going off, so I am going to go back on mute. It's not evacuate, no whoop yet. But if you could guide us through the wonderful name Bushlink and how you came to that.
Yeah, so we're probably a little bit measured in a way, because if we thought we put something just, widely out as a free for all, we, could end up with a whole gamut of suggestions. So
we had to manage expectations at that point, didn't we?
Yeah, we did. So we didn't want to sort of end up with, hundreds of responses. So we did a bit of an internal poll amongst, our staff about some suggestions. And then we sent sort of like a bit of a list out to the community members as well, and asked for their feedback sort of on a more of a controlled list. And between the two groups where we've done the consultation, and we've also got sort of, I guess, a guide here when we're naming our internal products. We don't want anything too, lengthy. We've got some other programs here like called Runway or Flight Bulb. So we wanted sort of like a 1 to 2 word, naming convention around the product. And I guess the feedback that come back was, and the selection was Bushlink. So, because essentially, you know, we're providing services to the bush, and this is linking, you know, the communities to this, you know, bush service delivery. So we thought that that was quite appropriate to name the product Bushlink. So, and it's been very well received.
And so connected to the bush run, which is what everybody was so excited about, that yeah, peas in a pod.
Yeah, it just aligned with everything. So
I'm going to get mobile and move outside away from this noise. But Hannah,
Yeah.
can you tell us about your internal engagement?
Yeah, okay. So the internal engagement that we did included all of our primary and allied healthcare teams, which are made up, of course, of the rural generalist doctors and our nurses, midwives, and then allied physicians. And we worked with the admin, bush run admin team. We did the same breakdowns of where are the pain points, what works really well, you know, what would you not want to see lost, all of that kind of basic workshopping. Went through a deep procedure of consistent updates to executive leadership to bring them on the journey with us and hear what questions they wanted answered. And then when we were ready to orientate the whole organisation, and that's about 450 staff across that central corridor, we rolled out some PowerPoint prezos and answered questions and did all of that. Yeah, is that answering your question?
It does. Yeah, perfect.
Yeah, great.
And I'll launch the second poll. I've moved outside, so I'm
Poor
outside
thing.
of all times, and it did start a whoop of evacuate. So I was getting people tap me on the shoulder. Perfect timing. But I'll start the second poll as well while we do that. So hopefully everyone will see that. And this is about what tends to be the hardest part of introducing a new digital service internally. So, you know, from staff, stakeholders, executive stakeholders, you know, we're all sort of either a bit change fatigued or just used to the rolling changes. I think as long as we can see the benefits, competing operational priorities and getting staff buy-in probably almost do come hand in hand sometimes. Like, you want me to do another thing? So definitely bringing people on the journey is tough.
We were so lucky when it came to Bushlink because that the health needs survey had really shown us loud and clear that the communities out there wanted this digital solution.
Yeah.
It was embraced by the board first and foremost, and it was built into the next 5-year strategic plan, and dedicated budget was given to it. And, you know, like, so it was definitely led by the organisation in terms of listening to the community.
And I know you developed some beautiful comms materials in all media of digital, printed handouts, posters, your website, and for everyone online, we will share a link to some of those because they're extremely well done. But so how did you sort of approach preparing the communities to use the solution and let them know this was coming?
It was actually a fascinating process for us, because in the work that we did in the site visits and then the digital consults, we started to hear loudly and clearly again that our corporate website at the time was really hard for our patients to navigate in terms of being able to find the services that they were looking for. And so as we were working out plain speak, simple, clean design for the Bushlink interface, we realised we needed to match that on our website. So we then had this quick response parallel project going to build a patient page that would mirror Bushlink, and that's the link you've just shared. Yeah, that was a really important piece of work for me to be able to hear that and improve that catchment. And so then we kind of rolled those out together, and we started off with a small pocket of bush runs, one of those cluster circles that Michelle was referencing before. Can't remember which direction we started with, Michelle, but
Yep. You're saying which location?
no, yeah, the direction. Was it bush run east or
multiple bush
northeast?
runs. And Michelle, you tell a really lovely story about a staff member who had never been on a bush run, who wanted to go on one to help the patients and onboard them and show them how to use it.
Yeah, so that was one of our I think it's a good news story because Grace, who's
Really
our
is.
admin assistant, like takes the phone calls, deals with the emails to actually book the appointments. So, and she was one of our integral stakeholders in, the development, of this as well, because she, accesses the admin portal and things like that. So we actually utilize Grace to actually go on one of the bush runs. So I think she'd been with us for about 4 years, but working in an admin role, so I'd never had the opportunity to go. So we armed her with a cache of user guides and QR codes, etc. And we put her on a plane to go out to one of the locations to be that at the elbow support to the community members. So, she was signing them up, talking to them about the program, because she was on the whole journey, with us. So, I think that was, and we actually got her to go out, I think 3 times, in the end so she actually got to see, and people got to put a name to the face that they would always speak to or communicate with. So,
and so did she.
Yeah, that's right.
They built that trust. They're like, Grace is telling me that this is okay and this is safe, and I can still be supported, and I don't have to use it, but it will help. Which I think is really great.
And it gave Grace a great amount of confidence as well in the system, because she was interfacing with it at the same time and learning it, and she is the one who is at the end of the phone. If they've got a problem, they call Grace. So
she's a superstar.
It was fantastic to have that.
And she just found it an amazing experience to be able to do so. That sort of, it gave us, I think, a warm fuzzy feeling, as well, to make sure that she's not just a voice informing it, that she could actually be a face to be involved in it as well. So it was really good.
And then thinking sort of, are there any learnings out of the launch that other healthcare services could use, noting that your healthcare service is quite unique and individual, but what advice would you give, through this launch of what worked, what didn't, and how they can, take on board the great work you've done? Maybe Hannah?
The advice, well, I think that listen, that exactly what you were saying before, Rachel. If you're going to ask the question, be prepared to hear the answer and respond accordingly. So, so ask the questions and be prepared to listen. Yeah.
I think we're at the point now where we've just had its Bushlink. It's had its first birthday, so we're about to go back out to community to sort of like ascertain more feedback, like what's been working, what can we still improve. I mean, we've had feedback around alerts, or not alerts, I guess reminders, like there's a booking confirmation, there's a reminder 24 hours out, there's a reminder on the day out, and some people are getting them via SMS and email. So some of the feedback has been can we change the volume of the alerts and the mechanism. So we'll take that on board and look at building that into some changes. We had some concerns around patients making duplicate accounts. So we want to put some mechanisms in play to sort of like minimize that. So, we'd sort of, and that came through feedback thinking the system's not working. But there was some challenges around a duplicate account and an appointment that had been booked on that account and not being visible, properly when they logged in with the correct, account. So we want to try and, minimize that. So again, it keeps that user experience consistent and, doesn't impact their view of the product. So
sometimes it's a happy medium, isn't it? Like we sort of want to build as many reminders and notifications and alerts into the system so people don't miss information, but then you don't want to bombard them with multiple text messages. So it's the happy medium of we're giving you the right information at the right time in the right medium, versus you're not getting sick of us and you're going to opt out of the digital platform.
Yeah.
I'll launch the final poll for those online. So the final poll is, what communication channel has been most effective for reaching your communities or patients? A lot of the large public health services we work with still use letters to send out information. And I think posters and flyers, some people still really love that tangible printed documentation. SMS for sure.
Yeah.
And interesting, we've got no sort of posters or flyers or phone calls, but definitely SMS, email, and social media, which is, I guess, the world that we live in now. I'll share those results for those online, so you can see.
Yeah, so I guess SMS
SMS
was one of our clearest, preferences as well. So,
and that's what I would prefer as a patient. Send me an SMS reminder, and even if you think like native apps, if there are, you can turn off your notifications. I'm more to ignore push notifications than an SMS for sure. So then, as we sort of come towards the end, how are you continuing to get feedback from communities about Bushlink? Your patients are evolving, the needs are evolving, and they're getting used to the digital medium and probably coming up with other things that they'd like. So Hannah, I'll go to you for this one.
We've got gymkhanas and rodeos and meetups and utes and motorbikes and all of that kind of stuff. So we will always have a presence at those kind of large community gatherings that are bringing people in from across several stations into towns or roadhouses, and that's a great time to take advantage of everybody in the same place to generate conversation amongst people or to have a pop-up kind of engagement. And then we'll, like Michelle was saying, we're celebrating our first year and we're at the point where we'll take out evaluations, and we can do that over the phone with QR codes, SMS. So there's a range of ways we'll do that as well. It's interesting in that poll that you just put up because community champion, so / organisation, is a great vehicle for us to get the word out. There's a woman who runs the post office at Andamuka, which is an opal mining town, and she said to me, no one's going to read a poster, no one's going to read a flyer. If you want the word to get out, tell me, I'll tell Jim, and everyone will know.
Perfect, like a bush telegraph.
Exactly.
Exactly
right.
Oh, that's so great.
And I guess the other feedback when Hannah mentioned about the gymkhana, like the community that is now like our biggest, utilisers that were the squeakiest, wheel to start with, we actually celebrated their, utilisation by doing a big poster that sort of highlighted, them in comparison to other, areas. And we took it to their gymkhana in that community and, just celebrated that success and, acknowledgement, back to them. So to keep that engagement, going. So, that was.
As they came through the gate, they saw this big gold medal saying, congratulations, you're at the top of the leaderboard for Bushlink.
That's so great. I haven't heard that story. I love that. Yeah. So you're 1 year down, I guess. What's next on the horizon for digital health, Bushlink, outside Bushlink? What's next? You guys are pretty innovative.
Yeah, so we want to now expand the solution to bring in our mental health teams and our allied health teams, potentially our dental, teams as well. So some of the messaging that's been coming back is that the communities want to book these other clinicians as well. So we're working through what that looks like because they currently manage sort of their availability and their calendars in a different system. So it's a bit of a workflow change. So it's sort of, looking at what those impacts are to sort of like bring them along, with the ride as well. We have 4 fixed remote area clinics as well that communities can go and see the remote area nurses for health assessments and things like that. So we want to also then bring in the ability for the community members to book into those clinics as well, not just the fly-in clinics. And we've also got a new GP service that's coming in later this year that's opening in Port Augusta. So that brings in a bit of a different model of care and sort of some enhancements that are required to the system because that is booking to a fixed location and being able to select a set clinician. So we're looking at how that model will evolve as well. And then we just, obviously, how can we then bring in booking telehealth services outside potentially of these fly-in clinics? So, I mean, we may service a community every fortnight, but what happens if they need someone outside of that, fortnight? Can they still book a telehealth appointment? So we're looking at how potentially, that might come in. And then again, integrations with other systems, My Health Record, and then, where can AI potentially, have a touch point in this process as well. So we'll sort of like look at where we can bring that in. So that's our little roadmap for now.
Very exciting roadmap, and I have no doubt that you'll do it all and do it exceptionally well as you have with Bushlink. Look, we're at time, so thank you so much for such an interesting discussion. Congratulations on such a successful project, and I think it's really admirable the way that you do collaborate with your communities. You know, even I think public tertiary healthcare can learn a lot from it. You might do it in a different way going to them, but we should definitely listen. And it does bring interesting requirements and does help drive uptake. And yeah, once again, congratulations and thank you so much for your time. I have shared the links to a couple of your resources in the Q&A. So those online who want to go and have a little sticky beak, have a look. The material is very user-friendly, plain speak, appealing to the eye as well.
Thank you.
Thank you,
everyone.
Thanks,
We'll share
Rachel.
a recording.
Thanks, everyone.
Well done.
Thanks, everyone.
It's over now. Thank you.
Bye.
Thanks.